Good evening, everyone. Thank you very much for attending this engagement event tonight. My name's Warren Tolley. I'm Deputy Chief Dental Officer for Welsh Government, if you don't know me. And for those of you that have attended before, you'll be fairly familiar with the format of this programme. So there'll be a series of presentations followed by some sessions in your chosen breakout room. Also, just to remind you, there is the Slido chat bar where you can enter questions and comments throughout the evening. And I've also been asked to remind you, don't forget to fill in your evaluation form so you can get the relevant CPD. So without further ado, I'm going to introduce Professor Andrew Dickinson, who's going to give you a short presentation on the principles of contract reform and also a programme update. Thank you very much.
Many thanks, Warren. Good evening, everybody, and thank you for joining this event tonight. We greatly value the fact that you give up your free time, particularly after a busy day, and your contribution to these engagement events is invaluable. But I'd like to start the evening just giving you a bit of scene setting before I introduce our speakers. So can I have my first slide, please? Now, I'm aware that there have been many, sorry, next slide, please. Thank you. I'm aware that there have been many questions recently asked around the reform programme. So it's a useful time to just refresh what are the objectives of reform and why are we undertaking reform at this particular time. Firstly, dentistry, like the rest of healthcare, is experiencing some significant and deep-rooted systemic challenges. While these have been magnified by the recent pandemic disruption, these issues have been with us for a long time, and some might say even to the beginning of the NHS. So as such, we have multiple challenges which are really complex to address and can only be resolved with everybody coming together to try and generate and produce a coordinated response. So this can't just be from one particular group. It has to be taken through policy, with the profession, and with public engagement. Secondly, as we're probably aware, previous contract reforms have had inherent issues, which is why there is probably unlikely to ever be an ideal contract, or certainly an ideal contract that is good for everybody. And this is because the issues are so complex. And so despite the fact that we've tried to address these from within the dental profession in the past, which has probably led to comments such as tinkering around the edge and marginal gains, we've reached a position where if we are going to make a lasting change, then we have to do that from within the system and go for a full reform of primary, community and secondary care. So thirdly, we need to make it a lasting change, and that in itself is difficult, but we've got some guiding principles that we follow with the reform programme. The first is there are those that actually push the innovation forward, the ones that are live at the current time, such as access, workforce, and addressing the inequalities that exist within our society. But we also have other opportunities to influence it. They're the pulling forward ones. And this is why we've had a lot of discussions within various work streams, engagement and listening events as to what are those creative opportunities that we have at the current time that we can put into a reform programme. Next slide, please. So when we started the reform discussions last year, the principles that we generated had come from pieces of legislation, a previous Senate inquiry, the Steele report, which, as we're aware of, has been around for about 14 years now. And all of these have highlighted there was a need for change. We're currently awaiting the publication of the recommendations of the 6th Senate inquiry, which happened at the end of 2022. But I'm anticipating that it is likely to cover the areas that we've put within our reform ambition. So that's around widening access, particularly looking at urgent and emergency care, the workforce challenges, which we'll be discussing tonight, looking at the quality of care, again, which we're going to be picking up in our breakout rooms, and then incentivizing prevention, which again we'll be covering in terms of cluster and collaborative development. But I think ultimately I still want to pose the question, what does the profession want from reform? And I think we need to have that open discussion, and I think that maybe that could be a focus for some of the breakout rooms this evening. Next slide, please. Again, there may be some confusion about the process guiding the reform programme. This isn't something that's just being developed in behind closed doors and without wide consultation. It really is a co-designed process. And as these two diagrams show, we're having multiple layers of conversations with many stakeholders, all of whom have been contributing, including the public and patients in the reform programme. Next slide, please. So I asked the question, what is the direction of travel? And I think we have understood that we're moving from a time of task performance where we've just been trying to hit targets. And I fully appreciate that people say that we're still dealing with targets. But as we saw during COVID, we moved to a more adaptive approach, a lot more flexibility and agility in the way that we were delivering our services. And I think this leaves us with a real opportunity to look at the context of how we deliver services going forward. And while I think this has raised a lot of questions, I think it's very valuable that those questions have been asked, and these are the ones that we're working with as we continue with this reform programme. So my final slide, please. So just really to refresh against the reform timeline. And this was proposed in the September engagement event. So we are in rapidly changing times, and there are some key and quite significant changes ahead, particularly within the coming financial year. And this is the reason why we've chosen the topics for the breakout rooms this evening. So we're entering 23-24 with potential key pieces of legislation that Vicky will be covering. Kirsty will be updating on some of the exciting workforce initiatives that are currently underway within Wales. And Adam will give an update next on the progress of the cluster development. But I think, again, I keep trying to bring the discussion back to the fact that there are some live changes which we have to work with, and dentistry can't just be making these changes by itself in a silo situation. We've actually got to work across the entire system. But in terms of reform, we're looking towards moving to the final stages of a discussion around the new contract, looking towards 2024. However, to achieve a new contract, there must be an underpinning system reform. Otherwise, it will just be another tinkering around the edges, which will not give us the sustainable change. So once again, I really thank you for joining us this evening. We do value all of the contributions. And as Warren said, please use the Slido function so that we can capture any of your comments, questions, and particularly your solutions that we can feed into the entire process. So now I'd just like to say enjoy the next hour, and I'd like to introduce Adam Porter to give us an overview of cluster development. Thank you, Adam.
Thank you, Andrew. So I'm going to be talking to you about accelerated cluster development, or ACD, and the topic here is where are the opportunities to influence cluster development. So I'm the lead on accelerated cluster development in Cardiff and the Vale, and all the health boards are moving forward with their ACD programs in their own ways. Could I have the next slide, please? So this is a meeting that I recently went to where everyone was given a pad of post-it notes and a pen, and we asked everybody to write down the most common physical, medical, and social conditions that their dental patients experienced. And then everyone stuck their 5 biggest priorities onto the wall. And then they all voted using little stickers on the conditions that had the greatest impact on their patient's oral health. And if they wanted to, they could put more than 1 dot onto a post-it note if they felt very strongly about that condition. So then we could form a ranking. We could reposition these different conditions into an order of what were the ones that were the most pressing, the most significant for the dentists and their teams. And this is the results that we came up with in that first meeting. So as you can see at the top there, stress and mental health got the most votes: smoking, diabetes, dementia, alcohol, old age, mobility, cancer, heavily restored dentition, you know, all the things that you would expect that we see day to day as dentists in our practices. Next slide, please. So that meeting was the first dental professional collaborative meeting in Cardiff and the Vale. So a professional collaborative is a group of people who come together to promote inter and intra-professional dialogue to improve patient care and experience, and to gather professional and user experience of the health and care system to inform priority setting and planning. So we started in this meeting to explore those population needs a little bit more. So we started looking at what possible solutions we could come up with as dentists to improve our service for patients with our 12 most voted for conditions. And these are the things that the group came up with. So a lot of people felt it would be really good if we could share the medical history with other professionals, if we had access to the patient's medical file. That might be helpful. People were talking about referral pathways for diabetes, for dementia, maybe referring people for exercise classes to help them with their mental health and mental health counselling. Oral health classes for dementia carers that could take place in the dental practice or maybe in care homes, perio screening for smokers and diabetics, and integrating a diabetes diagnosis into the dental examination. And then there was talk about advertising and promotion of oral health initiatives, and combining sessions with dentists, GPs, and pharmacists around alcohol abuse. So these were just some of the ideas that were coming out of that meeting. So the ACD program, Accelerated Cluster Development Program, that's the primary care component of place-based care delivered through professional collaboratives and clusters. So it's two slightly different things, professional collaboratives and clusters. And what we've talked about so far is the professional collaborative meetings. But working as a cluster ensures that care is better coordinated to promote the well-being of individuals and communities. Next slide, please. So here's the key point, really. We need your help to do this, because the whole point of the ACD program is that it's built from the ground up. It's about you developing and evolving the health services for your local population, because you know your patients and you know what they need. Next slide, please. So what can you offer? Well, every profession, whether it's general medical services or pharmacy or optometry or dentistry, every profession has a unique perspective on the health needs of their population and on the delivery of services. And every practice within that profession has their own unique perspective on the needs of their specific patients. And then every individual within that practice has their own ideas and experiences to bring to the table. So this is an opportunity to bring all of those different perspectives together and then use your expertise to try and shape healthcare services for your local population. So you may have heard of clusters before. Clusters have been around for a while. They were established in 2010 following a strategic program called Setting the Direction. And there's 64 different clusters across Wales, each serving a population of around 25,000 to 100,000 patients. There are 9 cluster areas in Cardiff and the Vale with varying focus and maturity. So these clusters in their old format were quite heavily dominated by general medical services, and dentistry really didn't have too much involvement. There were a few opportunities where dentists would turn up, but they got, they didn't manage to make much of an impact. But things have changed a lot with this new system. And you find that some of those clusters are now, they were quite mature, they'd developed quite a lot. Others really hadn't developed all that much during those years since they were first established. The health boards are responsible for the health of their population. And so that involves assessing the health and well-being needs of their populations and planning and securing services to meet those needs. And there's funding available for this. There's around £20 million of Wales government funding available for cluster working. And the health board is there to support through their locality teams. Okay, so this is a picture of Cardiff and the Vale, just as an example, with its 9 different cluster areas, and you can see that they cover different geographical sizes. Some cover quite a wide geographical area, but in terms of population size, some of those smaller areas have very compact populations. Next slide, please. So this is an overview of how the ACD program works. So in this bottom box there, we've got professional collaboratives. So a professional collaborative is a group of professionals from one profession who meet together to discuss ideas, projects, solutions to feed into population profiles for their cluster area. So this would be a group of dentists would form a collaborative. a group of doctors would form a collaborative, a group of optometrists would form a collaborative. Okay, but right now we're talking about dental collaboratives, and that would just be dentists. At the cluster level, what we've got is a representative nominated from a collaborative who attends the cluster. So you'll have one dental representative, one pharmacy representative, one GMS, General Medical Services representative. Okay, so one doctor, one dentist, one pharmacist, one optometrist meeting in this cluster, and they start to develop projects where they can work together to improve the health of their local population. And then there's the pan-cluster planning group who oversees the whole thing. And when projects are proposed, it's the pan-cluster planning group who can look into the funding opportunities and all those sort of things. Next slide, please. So a key action for this year is to support professional collaboratives to form for all of these different professions: general medical services, community pharmacy, dental, optometry, allied health professionals, community nursing. Next slide, please. And again. And so the health board will support practices within the cluster footprint to come together as groups of local professionals during this transition year. And funding arrangements to do this are going to vary from health board to health board. Okay, so I would imagine most health boards will give you some sort of funding to attend these meetings, but those arrangements are going to vary. And each practice is going to be requested to nominate one individual to represent their practice at dental professional collaborative meetings, which will happen around 4 times a year. Next slide, please. So the first steps is for primary care teams to facilitate the coming together of dental practices within the cluster footprint by arranging the initial meetings. And during those first meetings, colleagues will be supported to do things like discuss the purpose and function of a professional collaborative, look at the terms of reference, and discuss who might lead that collaborative, who might chair the meetings, who's going to engage with other professional collaborative leads and the wider clusters. And professional collaborative meetings is what I was talking about at the beginning when I talked about that meeting with all the post-it notes and everything like that. That was how we've structured ours, but you could structure it how you liked. So the role for dental, the opportunities for us to seize are about recovery, restoration and sustainability, better collaborative working between contractors, business continuity. It's about quality improvement and enhanced service support, delivery and development. It's about helping to influence the growth and development of clusters as a multidisciplinary or multi-professional team, and to collaborate and connect with our colleagues with a common purpose of responding to the needs of the population. Next slide, please. So what are the benefits for you as a dentist representing your practice? Well, it's about innovation. Okay, you've got an opportunity to be creative and innovative here. You can shape the health services for your area. It's an opportunity to participate and get involved in a community of healthcare providers. There's an opportunity to develop new skills around leadership and develop your experience. And there's also opportunity, of course, for funding, for projects. There's money there for cluster projects specifically designed to improve your work setting and help your patient population. You'll get a financial offer for attending these meetings. And also, importantly, you get to give a voice to your profession within the wider healthcare system. These cluster meetings are going to go on with or without dentists. Okay, and so for us to be there, giving our voice is important. But we do understand that you're all extremely busy, really difficult time to be finding time to be doing other things outside of your practices. The meetings will be arranged by the professional collaboratives themselves and the clusters themselves. So hopefully they can take place at a time and a venue which suits you. They could take place virtually or they could take place in person. The professional collaboratives will meet around 4 times a year. The person who's nominated as the lead, they might attend cluster meetings as well. So that would be 5 or 6 times a year, but that's not for everybody. That's just for the nominated leads. And then the meeting lengths for these meetings, well, it's going to vary. You know, payments are likely to be on a sessional basis, but it might take 2-3 hours to have a meeting. I've attended some which have been an hour and a half. I've attended some which have been 2 hours. But it's going to vary depending on the projects you're doing. Next slide, please. And so that brings me to a close. We've got a breakout room a little bit later on where some of us are going to be discussing ACD in a bit more detail. But I'm going to hand you over now to Vicky, who is going to talk to you about duty of candour. Thank you, Vicky.
Oh, thank you very much, Adam. Good evening, everybody. Thanks very much for coming. My name's Vicky Jones. I'm Clinical Director of the Community Dental Services and Consultant in Special Care Dentistry in Aneurin Bevan University Health Board, as well as the current Chair of the Welsh Dental Committee. And Andrew emailed me a couple of weeks ago and said, please would you provide 10 minutes on duty of candour, and this is part and parcel of the Health and Social Care Equality and Engagement for Wales Act, and so I'll discuss a little bit about that this evening. Can I have the next slide, please? So for us in general dental practices, this begins on the 1st of April 2023 for all NHS bodies. There is a professional and a legal obligation to comply with duty of candour. And of course, many of you will already know that the GDC had a professional duty of candour in place since 2016. So this may not be news to you at all. But practices will need to ensure that NHS staff are aware of what their duty is and in relation to the duty of candour. Can I have the next slide, please? So, as I mentioned, the GDC already has on their website a number of pages, about 4 or 5, explaining exactly what your professional responsibility is for duty of candour. And this has been about open and honest with your patients when something goes wrong. And what we're talking about here is that you would need to ensure that if there was an event that caused harm to your patients, that you would tell them and contact them and let them know what had happened, and then you apologise, that you offer a remedy or some support, and then an explanation of the short or long-term effects of what the situation is to be able to support that individual. So what's happening in Wales is there's going to be an extension. It's become it's legalised now. So could I have the next slide, please? So what are those trigger questions? So if an event happens and a harm occurs to a patient, what are the trigger questions we have to ask ourselves in order to know whether or not we've triggered that duty of candour? So the first question, has the patient experienced or could experience harm from an unintended or unexpected? So if that's yes, you then have to ask yourself, is that harm moderate or above? And that means more than minimal, okay? And if it's yes to that, and was the provision of dental or oral care a factor in that patient suffering harm? And if all 3 answers are yes, then duty of candour is triggered. Can I have the next slide, please? The actual duty of candour team are going to produce a statutory guidance, and within the statutory guidance there will be appendices at the back for you to be able to look at should you think that you've triggered that process. And the first algorithm is an example of what you may be asked and for you to follow to make sure that you know whether or not that duty of candour has been triggered. Could I have the next slide, please? The next one is about reviewing that process and what you would need to do in terms of record keeping. Now, many of you know or would be doing this already in terms of the putting things right process, or even if you have an adverse incidence. So again, it'll be at the back of this document for you to follow. The next one, please. But what is different with duty of candour is about the notification aspect of it. And so it's really important that as soon as you know or you think that you've triggered the duty of candour, that this is the start date. And what you're expected to do is to contact the person or the parent or the carer of somebody that lacks capacity to speak to them either on the phone, through a video call, or actually face to face. And the purpose of this meeting is to acknowledge what has happened in the first instance, then to offer an apology. Now, offering an apology doesn't mean liability, but that is what you need to be doing, is offering an apology. You must explain what the information is known about at that time, explain what the next steps would be, offer your support. But the most important thing as well is to make sure that you provide contact details should that individual want to get back in touch with the practice to make sure or actually clarify some of those issues. So the next part of this process is different again, because you then have to provide written notification, and you have to do that within 2 days of having that meeting or that phone call with that individual. And again, in that letter, you would be asked to reiterate a verbal apology. You detail all the information that you discussed, and all what you may be doing in order to put things right for that individual, and also ensure that they've got a point of contact from now on. Have next slide, please. So what are your obligations in terms of making sure that the health board know about any triggers for duty of candour? Majority of us will not have any triggers from 1 year to the next, but should you do, what you must do is provide a brief description of the circumstances in which the duty was triggered, and then you need to specify any steps with a view to preventing a similar circumstances arising in the future. In other words, lessons learned. And this report needs to be sent to the health board, and it covers that financial year, a reporting year from April to March. And what the health board will do with it, well, they'll anonymise that data, and they'll put it in their annual report. And HIW will also include compliance with duty of candour and carrying out their inspections, as well as part of the GDS QAS system. Next slide, please. But the most important thing about duty of candour, regardless of all the processes that are in place, is one, that we recognise what we've done, be open and honest with our patients, offer an apology, and focus on what would be the learning and the sharing to improve patient care and service provision in the future. Could I have the next slide, please? So this is a dental example of duty of candour. So a patient attends the practice for recall, and the dentist finds that the patient has candidiasis due to poor denture hygiene. The patient is given denture hygiene instruction and prescription for miconazole oral gel. So 2 weeks later, this patient's wife calls the surgery to inform them that her husband had been admitted with a gastrointestinal bleed due to his INR being above 6. She said her husband had actually been placed on warfarin 4 months earlier due to a DVT, and there was and so when the practice looked back at the records, they noted that there was no update of his medical history for that last appointment. Can I have the next slide, please? So what we would do, we know an event has happened, we know harm might have happened, so we would ask our trigger questions. Was it unintended and unexpected harm occurred? Yes. Is that harm more than minimal? Well, yes, the patient was admitted into hospital with a GI bleed. And was the provision of dental care a possible factor? Well, yes, because he was prescribed miconazole oral gel. So with all those 3 questions, that's the duty of candour is triggered. And so therefore, we would ask you to go to your guidance document, back to the algorithms, and start to follow that process. But the other thing that we must need to take into consideration is that the fact that the pharmacist who dispensed the medication should also be contacted to follow the duty of candour process. And I would be asking the wife where that prescription was taken to and who dispensed the medication. But an alternative scenario would be that the pharmacist, on receiving that prescription, actually checks the patient's medication and then refuses to dispense it and lets the practice know that this is what they've done. So no more than minimal harm has occurred, and so therefore the duty of candour does not apply. However, it is an adverse incident, and therefore the practice would have to follow that process, either completing their own internal practice incident form, or in the future we may be completing the Dartex Cymru, which is a web-based form that may be rolled out in the near future for dental practices. And what that practice would need to do is review its medical history taking process, and as part of lessons learned, and actually feeding that back to the practice about what possibly at practice meetings, about what you were going to do to ensure this does not happen again. Could I have the next slide, please? So My final slide is just what general dental practices would need to do to ensure they're complying of duty of candour. So all GDC registrants need to understand their responsibilities. So within your practice, if you've got a putting things right lead or a concerns lead, they would be probably the best person that could take on the role of looking at the process for duty of candour. So all of you, and I would suggest in a practice meeting, would need to have some awareness raising, education and training of your GDS teams. And I know that the duty of candour teams are actually putting together a video and information that they will be rolling out and sending to primary care leads, so that will go to your practices from the beginning of March, so that you'll be able to look at that and discuss this with your teams. The other thing that you would need to do is ensure that you've got a policy on notification and monitoring. And I would probably suggest that that goes on the end of your putting things right or your adverse incidents type policies, so that you know where it is. And then sharing that learning, sharing the learning is the most important thing. And that is where you would have to have evidence within your practice what you did to make sure that this incident and this harm and this trigger of duty of candour doesn't happen again. And finally, ensuring that you provide an annual report to the health board of the processes that you followed and the lessons learned. And on that note, thank you very much for listening, and I'm going to pass you over to Kirsty. Thank you.
Thanks, Vicky. Good evening, everybody. Most of you know me, I think. My name is Kirsty Moons. I'm the Postgraduate Dental Dean in Health Education Improvement Wales. I have an awful lot to get through with you in 10 minutes on workforce, so apologies in advance for how quickly I will speak and how much information I will give you. Hopefully you will find it informative. Next slide, please. Workforce is a huge part of what HEIW does, education and training and workforce. But I just want to give you some reassurance and some context in terms of where we are and what we're doing. We are developing a workforce plan for dental, but we are not doing that in isolation. There are a number of other workforce plans currently. Some of them are out, mental health you may have seen, some of them are not. Next slide, please. And we are not doing this in isolation, we'll be working with the others. There are 3 key strategic aims that HEIW has about building the workforce, developing the current workforce, and shaping culture and leadership in the NHS. We have work within each of those strategic aims, and we will be engaging with stakeholders as a priority to take the work forward. Next slide, please. We have committed to develop, publish and plan an implementation of a dental workforce plan. That's a massive undertaking. But one of the things I will say to you this evening is workforce is not entirely within HEIW's gift. We can convene it, we can host it, we can pull you all together, we can draw in your ideas and innovations, but it is something we all share. So my call to action to you all is to get involved in this. Next slide, please. There is a well-shaped, well-formed method of developing a workforce plan that we will follow. Is well-trodden path, and we will use the same path to develop the dental workforce plan. The first of that, the 3 pillars effectively that will run in parallel. Engagement, massive part of this. We will be engaging with you all. This evening is the start of some of that, but there will be some dedicated engagement events. We have to be clear about the scope of this plan, what's in, what's out of scope. Andrew talked earlier about system reform and the wider piece. And, you know, we can't do everything, so let's be clear about what we can do, what we can deliver, and what we can commit to. Data, I will talk about in a little bit more detail. Next slide. And research and best practice and horizon scanning. We've got masses of information, but again, that'll be part of our engagement piece. Next slide. So data is a real problem for us in dentistry, as many of you will probably know. The data you're seeing on the slide now is GDC data. It's all we've got in terms of how many registrants there are in Wales and what roles they're doing. And you can see in the green the figures there for Wales. But it doesn't tell us where the workforce is, what it's doing, the scope of practice, how many hours they're working. It doesn't tell us anything that's of any use in terms of forming a workforce plan. Now, data isn't everything. You know, we know there's a crisis. We know there's a recruitment and retention problem. So we've got to get on with that in the meantime. However, to form an evidence-based plan, which was just clinicians, you know, that's what we're used to, we have to draw the data in. We have good news on this. You know, there are some sources, some of the employed sectors have ESR that you'll be familiar with. You have the quality assurance QAS that you submit annually that we draw some data from. But there will be a system coming out this year, the Welsh National Workforce Reporting System, that has been in general practice for a number of years. It will be rolled out to dental practices at some point this year. You'll be seeing comms come out around that. It shouldn't be any more onerous than QAS has been. In fact, it should be easier and better because it's a live system. Adrian Thorpe has been leading on that, and QAS data will be migrated into it. But that will give us the first time some insight into what the workforce looks like, where the problems are, where the holes are, and the key areas we need to address. It's a really big part of the work that's going on this year. Next slide, please. Just take a moment to think about innovation and what that means. Just take in this slide a minute. Evidence-based organizational practices that enable employees at every level to use and develop their skills, knowledge, experience, and creativity to the fullest possible extent, simultaneously enhancing business performance, engagement, and well-being. Huge. I mean, when we're talking innovation, we're not just, we're not coming up with the quick wins. Some of this is long-term stuff that Andrew referred to earlier in the strategic direction. And it's something that we all need to think about, everybody. And some of you will be trying innovative practices in your areas and in your practices and in your surgeries. And some of you will have tried them and they won't have worked. So we need to think about the levers, what works, what doesn't, the barriers, what's in our way of these things. And all of you, when we go out for the engagement, all of you need to feed these things into us so that we can build and form that. Next slide, please. We know there's a crisis. We can't do the same things because we're just going to keep getting deeper and deeper into this crisis, which is where we are now. We need to be able to flex, adapt. We've got the burning platform. We need to now capitalize and start doing things differently. And that's where we're starting to see some of these disruptive things coming in, opportunities, innovation, things that we're doing differently. We're having to look and think about what the workforce needs. We've done a lot of scoping, a lot of focus groups. We know that people want to work differently. They don't have the same desires in terms of careers that us old folk did. So we've got to do different. We've got to accommodate a different workforce. Next slide, please. There are challenges, and we need to talk about those and recognise them. We know there's huge well-being and morale issues partly because of the workforce crisis that we're all experiencing. I won't iterate everything on that slide, but we're seeing, a number of things that we've not experienced before. The work-life balance, great, and I do think maybe this generation knows something that the rest of us didn't at that age, but that means there's a reduction in the hours worked. So we've got to look at other ways of filling that gap. And then the migration from NHS to private, a big challenge. And what's causing that? What's underpinning that? And let's look a bit more closely at what we can do to try and reverse that trend. So there's lots of things that are challenging the innovation at the moment. Next slide, please. But there are also opportunities. And Andrew talked about system reform, skill mix. I'm going to talk about a little bit more because it's still very much part of the plan. Workforce plan, we've got to increase training places. There's lots of things going on, and there's lots of things we're doing in this space. And I can't go into detail, next slide please, about all of them this evening, but here's a taste of some of them. And within this, there is a lot of attention on dental workforce, which is fantastic. We've waited a long time in dentistry for the spotlight, to be honest. Well, it is. So let's all stand up and let's all make this count, because not often those windows of opportunities present themselves. A lot of work going on. We're developing a GDP fellowship options, looking at flexible training pathways. Longitudinal things are interesting. We're surveying existing fourth and final year undergraduates, what their career preferences and aspirations are. This is a huge long-term piece of work, and there are massive different things that we need to explore. So we'll be engaging with you for all of these. Next slide, please. The policy direction about skill mix is very clear, and I am going to touch upon this, and Andrew referenced it, and that's been going on for years. But the policy doesn't always align with some of the realistic challenges in business, and we know this. There's been research done that a lot of us have been involved in. You'll have seen some of the announcements in NHS England about therapists opening and closing courses of treatment, and there are still some challenges within that, prescribing, various things. I think one of the things we are very good at in Wales is how agile we are and how able we are to talk to each other and influence change. I do believe that we will be able to learn from where England is and do things better and differently. But next slide, please. But let's recognise it's not a perfect system, as Andrew said. There are challenges, there are problems, and we do have to think differently, and we do have to recognise that. We don't pull together well as a profession. We're all pulling across it in our different component parts and looking at what works for us and not thinking about each other enough. We need to work together as a profession. We need to be singing with the same voice, and we need to be recognising that we've got to do things differently and work together. And I think that's my call this evening. Next slide, please. I'm going to put this up because, and I don't think it's particular to any part, but I do, and it's common across all the healthcare professions. But I do think it's worth me calling it out. Some of this stuff is unconscious. It's conscious and it's unconscious. And I just want everybody to stop and pause and think about these things. That everybody can make a change, everybody can make a difference, but we've got to do it collaboratively together, or it will not happen. Final slide, please. This is my last slide, and it is just reinforcing that call to action. Everybody here, everybody this evening is here because they care, because they want to do something different, because they believe that there is time for change. Then let's step up. When we start engaging with you in terms of workforce, please engage, please respond, and please let us know what's going on. Thank you. I'm going to hand you back to Warren now, who's going to take us into the breakout rooms.
Thanks, Kirsty. That's great. And you're not old. If you're old, I'm even older then. Okay, folks, it's now time to go into breakout rooms that you've chosen. So we'll see you later. Thank you.